Thank you, sir. Yes, thank you, sir. Um, After a very captivating lecture from Dr. Elendarayan, I feel like in a one-day cricket match, the opening batsman has hit a 200, and I'm just walking in to face the bowlers. And I hope I can do justice to this topic. And before I start, I should really thank Dr. Sendil, our president, and Dr. Rajendran, our treasurer, and Dr. Suresh Balan, our secretary, for giving me an opportunity to essentially condense what is a whole day program. The I think very shortly the IAP, I think on 30th, has got a workshop on preschool Wheeze on full day. So what they are going to talk in kind of one whole day, I'm going to do it in the next 25-30 minutes. So I would start without much delay. Basically, this whole lecture is going to be based as though we are in a OPD setup and how we are going to go about. So, what do I really try to achieve in this talk? One is to outline the approach to a child who presents with a noisy breathing. Mother comes in and then says, "My child has got a noisy breathing. I am worried." The question is, should we be worried or not? And of course, to look at the various treatment considerations for a preschool child with a wheeze, how to go. I mean, we all know that recurrent wheezing is a very common problem in school children, in preschool children. It's a breadwinner for a lot of us. I mean, among the three common areas we look at, one is diarrhea, another one is the respiratory tract, and third, of course, is our immunization. That's what helps us to survive in primary care. So definitely, it does help us in a huge way. And but please remember that a lot of children who wheeze because they have a viral respiratory infection and not because they have a reactive airway disease or some other problem. In fact, more than 80% of all children who wheeze because they have a viral respiratory infection. Now, when I talk about a preschool child, I basically mean a child between 1 and 5 years of age. Now, the first question when the mother says that my child has got wheeze. Nowadays, parents are very intelligent. They look at Google, they look at WhatsApp, and then they come and give us the diagnosis. They say, my child has got a wheeze. Give some medicines for my child. And my response normally would be is, if I cannot hear it on the OPDs, kindly record it on a video and bring it back. And that really helps to differentiate rule of the thumb. When a mother comes and says that I could feel the rattle, மேல பின்னாடி வந்து முதுகுல கையில வச்சா கரகரன்னு சத்தம் கேக்குது. That's what they typically say, isn't it? Please remember that a wheeze very rarely is felt like that because wheeze is an expiratory sound. So the sound goes away from the chest, whereas all the other three, which we have just told, the stridor, the snorts, and the stertus, they all are inspired, which means the sound comes towards the chest, so they are more likely to feel it than the uh, wheeze. Now, I think it's really important for us to understand why wheeze occurs, and because that will kind of make us understand our treatment approaches. Now, there are four reasons why a child wheeze. The first and the most obvious reason is that there is a lot of smooth muscles in the bronchi. and for whatever reasons they just go in for a constriction, and that causes a narrowing of the lumen, and the child can produce a expiratory wheeze. The second reason, which probably is a more common reason in children, is edema of the epithelium of the airways by itself. And when a child has a lot of edema, then trying to give a bronchodilator obviously is not going to work. And another important reason, particularly happens in smaller children, is denudation of the epithelium, which kind of acts as a mechanical block. It basically narrows the airways and produces a wheeze. And again, in these children, bronchodilators will not work. That is why we find that in some children we have a tremendous response. One nebulizer, the child is perfectly fine, whereas in the rest, you give even 3, 4, and still the child doesn't work. And the last but not the least is the role played by the mucus plugs. Now, mucus plugs again can block the airways and produce noise. So these are the most important reasons. And if you are looking at the physiological correlates of treatment, then you would find that bronchodilators work when there is a lot of bronchoconstriction, whereas when there is edema and inflammation, drugs are going to work. Now, I think just out of interest, we need to realize why wheezing is very common in preschooler. Obviously, these children have very small airways, so there is increased airflow resistance, and then it produces a noise. The second and more, less recognized reason is that the larynx is anatomically quite close to the upper airway, so the infections are more likely to spread from the upper airway to the larynx and beyond in the neonate, in a preschool child. And of course, these children have a very floppy epiglottis. Their pharynx is not very rigid, as a result of which they can tend to collapse and then cause obstruction. Again, this leads to accumulation of secretions and again can cause wheeze. Now, I think we are very good at making figuring out a wheeze, but what we also not good at is to making a diagnosis of wheeze. I mean, we often write a child as a wheeze or cerebral or just a simple wheezer, and then put the child on a treatment. Now, I think the first and the most important point we need to take home after this particular talk is that wheeze is just a symptom and not a diagnosis. So any child with a wheeze needs to be slotted into clinical syndrome. I like syndromes, not the complicated dysmorphic syndrome. I'm pretty pathetic with it, but a good clinical syndrome which helps us to guide us in treatment. What are the possible clinical syndromes a child with wheeze have? The first and the most important is basically a normal child. Okay, child comes in, he's got a bit of cough, cold, and then you auscultate, there is a occasional wheeze. And this is the forms the major chunk. About 70 to 80% of children belong to this group. And unfortunately, many of these children land up getting treated as though they are asthmatics. Now, the second syndrome where we need to slot in is a child who's got a multi-system underlying illness. There is often a lung involvement, and then, okay, fine, as part of it, you might have a wheeze. So, examples for these kind of conditions would be cystic fibrosis, primary ciliary dyskinesia, and bronchiectasis, and many more things, subglottic stenosis, and many more of them. They are relatively rare, but it's really important for us to identify, because otherwise these children just get treated for their lung problem, and whereas the rest of the problem is just not identified. The third group is basically a child who does wheeze, but these children have normal lungs, but there are conditions which predispose them to cause to present with the wheeze. And usually there are two conditions which come under this particular group. One is a gastroesophageal reflux, particularly in small children with GERDs, and second group is children with chronic rhinitis. Basically, the secretions kind of enter the respiratory tract while the child is sleeping, and the child develops a wheeze. The lungs, nothing wrong with it, and then it is important because our treatment protocol is very much different. The last but not the least is the children who have a true wheeze. Okay, this might be among the wheezes. If you look at it, maybe about 15% of all wheezes. Now, within those, there are two different phenotypes, and This is a concept which has come in the last maybe 10-15 years. Of course, it's already being disputed, but as of now, it gives us a lot of simplification and also helps us practically to approach the management. So I think it's worth understanding a bit more about those. So one, either the child goes into a category called as episodic wheeze, and another one is multi-trigger wheeze. Now, like always, history and examination plays a very major role in helping us to slot the child in one of these four categories. Now, probably the first question we need to ask is, when did the symptoms start? And if a child starts symptom in the first year, and particularly in the before the 6 months of life, it's likely that there is a coexisting systemic illness. It's not a simple straightforward visa. Now, the second point is about the onset. I mean, particularly in the first episode, okay, and a child could have easily started, I mean, who's been playing, could have easily started suddenly with a foreign body and then land up with recurrent infections and a wheeze. And if we did not take this history, we would have missed a foreign body, and then this child gets treated lifelong. I still remember a child whom my professor, Dr. Srinivasan, has told when we were PGs. I mean, he said about a person whom he met in the train about his 8-year-old child who developed bronchiectasis because of a missed foreign body which the child obviously had when it was younger. I mean, so foreign body is something which we need to always keep in mind, and a simple history would definitely help. And if a child has symptoms which never resolves, okay, don't brand it as a case of unresponsive bronchial asthma. Again, it could be an indicator of something else. Our diagnosis basically might be one of those children who has got a systemic illness or one of the respiratory mimics rather than a wheezer. Now, if the child has a type of cough, I mean a wet cough, it basically suggests that there are a lot of secretions, and again, which is not a typical feature of a true wheezer. Diurnal variation does help to kind of slot in a child with a wheezer, because a child with a wheeze very often tend to be worse at night rather than during the day. And a good response to inhaler therapy. I mean, the child has presented with difficulty in breathing, severe cough, is wheezy. Just give him a single dose of nebulizer, and then you bring the child back, or even a inhaler, and then the child looks absolutely fine, as though nothing ever happened. That child would be very useful that history will be very useful to categorize this child. Last but not the least would be the presence of a viral illness. Now, children always tend to have a lot of runny nose, and so it's not very easy. But please remember, a child who has runny nose, who has got a bit of fever, maybe coryza and congested eyes, and I mean, now normally we won't look into the throat in this corona period, but otherwise, if we manage to look into throat, we find a congested tonsils, that would suggest there is a um, viral illness associated with this VC episode. And the need for hospitalization is important, not from a diagnostic point of view, but it is important in the past. I mean, if the child has ever been admitted in the past, it's important for us to decide about the need for a preventive. For that, the history is important. So what are the systemic histories, illnesses which we can identify from history? A recurrent otitis media might suggest a primary ciliary dyskinesia. I don't think it's rare. It is rare, of course, but I have seen at least a couple of those, so it is possible that we can miss it. A child who presents with vomiting, who is not very keen on breastfeeding, the moment baby is put onto the breast, the baby arches away from the breast, and of course, who is just not feeds very well, is most likely to have a severe gastroesophageal reflux, and it is something we need to pick up rather than just kind of dismiss it. Children who have significant developmental problems, uh, obviously, the wheezing may not is more likely to be a micro aspiration rather than wheezing, true wheezing. And children who can have oromotor dysfunction because of again present with choking. Apart from that, a general kind of open question like any other system involvement, very often the parent walks in with the idea that they're going to talk about the chest problem, which is the major problem, and they may never disclose till you ask them, is there any other problem? And then they will just give you a big list. So it's always important to ask an open-ended question to these parents rather than to close it off with very specific questions. It is important to elicit a history of atopy. That atopy could be in the form of atopic dermatitis, it could be any food allergies, it could be a rhinitis, or it could be a past history of Wheeze itself. And that's not just that history is not limited just to the child but also to the family. And if there is a history of atopy, it is important to identify what is a possible trigger. Okay, and because trigger avoidance is the first and the foremost intervention we are going to do in these children. Now, what about the examination? There's not a lot to examine these children except for very few things. Look at the height and the weight. I mean, a child who is thriving well is rarely going to have a significant systemic illness. So it's really important to look at the height and the weight of the child. And yes, possible clubbing for presence of bronchiectasis, and pulse oximetry is very, very, very important. I mean, with the COVID, lot of the pulse oximetry has got a lot of importance. But please remember that. We are just not good at diagnosing cyanosis. So, whereas a pulse oximeter can always indicate show us an hypoxia much before a child's clinical cyanosis is obvious. So, it's really important to check the pulse oximeter, the oxygen saturation for a child who has got a significant breathing difficulty. A child who has got a severe chest deformity, obviously it indicates that this problem has been that right from the child has been quite young, and our diagnosis has to be different. Yes, and it's really, really important to identify the type of respiratory noise. Okay, just listen to it and then figure out, is it a strider, is it a wheeze, is it a stutter or a snuffle. I mean, it's very, very important because so many times it has happened that, that a child has been misclassified because somebody has just not bothered to look at the uh, type of noise. Asymmetry of signs is important because it could be a pointer towards a diagnosis of foreign body. Now, apart from that, okay, fine, I have figured out all this and then I know where I'm going to slot my child in one of those four. What next? And my next thing is, how aggressively should I treat? And for that, the work of breathing assessment is really important. So how will you go about doing it? We need to start with looking at the behavior. Irritable child, don't dismiss it saying that child is always scared of a doctor. It might be because this child is hypoxic. Hypoxic child is going to be irritable or is going to be lethargic. Okay. If the child is able to interact, is able to talk, you know this probably the work of breathing is not very high. Tachypnea is obviously very useful to figure out if the child has got a high work of breathing. And one important aspect about the intercostal and subcostal retractions is that we need to differentiate it. Is it with tachypnea or without? Some in smaller children, particularly in the kind of 1 year olds who has got a significant upper airway obstruction, they might have the subcostal recession, but they will not be tachypneic, and that is very, very important to identify. So not every recession has to be we should be worried about. A very sinister clinical finding which we need to look for is a paradoxical abdominal breathing. This child is very sick and obviously needs a admission straight away. And as I said, saturation anything less than 92, we need to be worried. And again, this child. So I've got a lot of history. I've got some examination findings. So how should I go about? So let's start with the child with the noisy breathing. Let's look at if there is systemic features are present. Fairly obvious, isn't it? This child is going to be a child with systemic illness related wheezing. Otherwise, it could be a wheezing mimic, that is like a GRD or a. What are the possible conditions we could look at? A child who's failing to thrive, who's got a steatoria, consider cystic fibrosis. Yes, it is. We used to always think it's very rare in the Indian population, but yes, definitely it does exist. Thanks to a lot of neonatal screening, we are identifying cases. I mean, there is at least one child in my care who comes with cystic fibrosis on OPD basis. I don't admit them so for OPD consultation. So definitely it does exist. A child who has got a severe, frequent, persistent, or unusual infection, always think of immunodeficiency. It's quite common than what we think. Okay, and a child with chronic rhinitis and recurrent otitis media, primary ciliary dyskinesia, again something which we have to think about. Persistent wheezing. Okay, A child who doesn't have a course which is kind of very static. Okay, it might be mild, it might be severe, but this child has got a very severe, I mean, the wheeze is always there. Always think of a obstructive lesion, and it could be a vascular ring, it could be some kind of a lymph node which is obstructing a bronchus, it could be aspirated to foreign body, and I think murmurs are fairly, we are good at diagnosing, so I don't think we should be worried too much about. But one last but not the least, which we should not forget, is about the severe regurgitation associated with the. Okay, so we have done that. So what next? So in case there are no systemic features, go back to what we always talk about: growth, assessment of growth. I mean, assessment of growth really helps to us to identify a sick child. So it is very useful. If the child has got a normal workout breath, even if you find a wheeze, put this child under a category of normal child with a wheeze and treat accordingly. All this child will need is some kind of bronchodilator. Now, how you would administer is entirely your choice, but probably the preferred option would be an inhaler, but if not, I would consider oral. If the child has got increased work of breathing, then we need to put this child as a true wheezer, and then we need to then try to slot them into one of the two categories. Is it an episodic wheezer or wheeze? So how do you go about differentiating the two? There are four questions to ask. One is the pattern of the wheeze. Second is there any coexisting atopy? Third is what about the intervening period? And four, is there any viral illness? But please remember that episodic wheeze and multi-trigger wheeze, though we keep talking about as though they are two independent spectrum, I mean two different phenotype. In reality, that's not often the case. Very often we tend to have a kind of a spectrum of this disease where a child kind of more slots into episodic wheeze, or it could be more a multi-trigger wheeze. So how do you differentiate episodic wheeze? The child has a illness, lasts for 4 to 5 days. Once the viral illness settles down, child becomes better and absolutely fine. Usually there is no coexisting atopy. In between these periods, the child is absolutely asymptomatic and is fine. And we very often find a viral illness with these children, with these acute episodes. Whereas multi-trigger wheeze, yes, the child is, the episodes can last from days to even a couple of weeks, with intervening period where they might be improvement, but they're never normal. Okay, they might have some nighttime symptoms, child might have some difficulty while in breathing while playing, or they can have some occasional coughs which are worse during day also. Yes, coexisting atopy might often be present, and usually the intermediate period, as said, will be of symptomatic with varying intensity. Becomes complicated, so the child can have a viral illness which could act as a trigger. But please remember, there is another classification which is basically looking back at the child. It's not, it doesn't help us in the treatment, but it kind of helps us for another child in the family. So, episodic wheeze usually becomes, the child becomes better within the first 3 years of age, whereas persistent wheeze, the child kind of becomes symptomatic in the first year and then keeps becoming better only at the age of 6 years. And then we have the late onset wheeze where the child very develops symptoms only after 6 years of age. Many of these children with persistent wheeze tend to be a multi-trigger. Okay. So having said all this, our treatment is more decided by the severity rather than do they belong to the episodic wheeze or a multi member. So how do we go about treating these children? We have three cornerstones. One is a non-pharmacological approach, probably the most important, which I don't think we give a lot of importance to it. We are more happy prescribing drugs. The second is obviously treatment of acute episodes, and the third is treatment of, considerations about. Now, if there is an obvious trigger, we need to avoid it. And there is one trigger which we don't realize and very often, and it's very important actually to avoid this. That is preventing viral infections. We know that many of these children have a wheeze because they have a viral infection. So how do we prevent it? And one very important way of doing it is using flu vaccination. Okay, our IAP immunization schedule talks about flu vaccinating children, giving flu vaccines till 7 years of age. But unfortunately, because it's not obviously printed onto the boxes, not very many people realize it, except for some of these educated parents. It's not getting really the due credit. Stop adult smoking in the family. Father often goes out and comes to smoke. Again, the child is going to have passive smoking. So it's really important not to get the parents or the elderly in the family to stop smoking. A third important aspect we need to give a lot of importance is trying to improve the reserve of the respiratory reserve of the child by getting the child to exercise. Thanks to all the televisions and the gadgets and the screen time of children is so much that they hardly play around. So the lung reserve of these children is so poor, and they got an excuse that my child, when he goes around and plays, gets a cold, gets a wheeze, so I don't want them to play. So their lung reserve is so poor, and it's really important to educate the parents about the red flag signs and also about the other. In fact, this forms the most important aspect of our treatment, not just the drugs which we give. But having said that, okay, child has come in with an acute episode. What do I do now? um, Obviously the choice is you treat them with a bronchodilator. Now, I've mentioned very clearly that inhaled bronchodilators is the drug of choice. And please remember all the guidelines, let it be the GINA or the BTS or the Canadian guidelines, every one of them talk about inhaled bronchodilators. Unfortunately, in India, we don't use it that often. We nebulize the child and send the child home on a syrup. Okay, I think the syrups have got a very big market. And actually, whereas I mean, during my stay in UK, I've hardly used to get a syrup of a bronchodilator. It's just not available. Whereas in India, it's just a thriving market. So we should switch over more to using a inhaled bronchodilator because there are a lot of advantages. We are not exposing the child to a lot of systemic side effects. We can use it as and when needed, and obviously the dosing is much lower than what we use in a inhaled oral bronchodilators. So beta 2 agonist definitely is a drug of choice, but interestingly in a older child anticholinergics also help, particularly ibuprofen bromide can be used along as adjunct to beta 2 agonist, not as a primary drug. So as far as possible, if you have got educated parent, better to avoid oral bronchodilators. Of course, economic considerations come in, but I think unless we do proper studies, all the use of oral bronchodilators is very much unproven. What about the use of oral corticosteroids? Again, it's one of those where the evidence is not very strong, unlike in bronchial asthma. So if a child is very sick and who needs hospitalization, who has got a severe workout breathing, who is hypoxia, it's only those children in whom we need to be open about giving oral corticosteroids. And even then at a relatively lower dose, not the 2 milligram per kg of prednisolone dose, but much lesser than that, maybe a 1 milligram per kg. Okay, definitely if the child does need a hospitalization, giving steroids. Okay, now let me make it very clear, there is no study, except maybe for the very small studies, there is no role for nebulized corticosteroids in the acute, treating the acute episode. I think this is something which we have been taught time immemorial, and it's something we have to understand. Very often it gets confused because see, nebulized budesonide, it works in group, and so it gets extrapolated for a child with wheeze, but it's not the case. Obviously, there is no role for any mucolytic if it is something which has to be avoided. And again, there's no role for any leukotriene inhibitor, montelukast or on one of his newer formulations, because they are just not good enough to treat in the acute episode. So, is there a role for a controller therapy? Um, See, this is the basic minimum which you would expect in a child with any kind of a true visa. So you should have daytime symptoms less than 4 per week, nighttime symptoms less than once per week. You should be able to have a normal physical activity. Its need for use of inhaled bronchodilator should be very limited, and you should have a very poor, rare or infrequent exacerbation, and you should never miss a school. If all this is there, these children don't need a daily. Obviously we need to consider the controller, and again the daily controller therapy is decided by the severity or the frequency of the episodes. Okay, obviously those children who got a very severe attack, those who have got frequent episodes, or sometimes our parents want to please us. They want to say, "Illa illa sir, there's no problem with my child. மருந்து கொடுத்தீங்கன்னா போதும் சரியாயிடும்." But the only thing is, you dig deep into the history, then they will say that for every one prescription we have written, they have at least given 10 or 15 times of their own repetitions. So if such a case, these children would consider, we should consider giving. So for multi-trigger bees, there's only one choice. It's a one and only inhaled corticosteroids. Um, I don't think the evidence ever points to adding a long-acting beta 2 agonist, and we need to just stick to the basic betamethasone or budesonide and see how the response is. For episodic V's, uh, this is where the choice of molecular inhibitors comes. These children, if you can identify, you tell every time the child gets evidence of a viral URTI, at the first sign you start the child on Montelukast, put them for a week or two, and then stop it once the child becomes better. Of course, if we land up using a lot of Montelukast, then we should consider putting even these children on inhaled corticosteroids. Please remember that Montelukast is one of those drugs which has got a lot of side effects, idiosyncratic. Okay, and their side effects, the idiosyncratic side effects are very severe. I mean, it has been attributed in soda lymphoma, it has been attributed in macrophage activating syndrome, histiocytosis and whatnot. So we need to be very careful about using Montelukast and not use it like the way we use it often. Is there a role for combination of Montelukast with one of the antihistamics? The answer is definitely no. Because as you could see, antihistamics by nature, they tend to thicken the secretions. And if we are going to thicken the secretions, if you remember the slide which I talked about how wheezes occur, you will realize that when we thicken the secretion, basically we are forming mucus plugs. It's not going to make things better. It will in fact make things worse. So is there a role ever for such a drug? Yes, there is a role for this combination, but only in allergic rhinitis and not other. Okay. But please remember, any controller therapy in a small child is basically a treatment trial. If there is no response, go back and look at either your diagnosis or say, fine, it's not helping this child, and stop it. Okay, get down to the lowest dose, effective dose, and not keep increasing the dose like we do it in a high asthma. And usually these children don't need treatment for more than 3 months. Again, it's very different from what we do in a child world. So let me just go with about 5 cases and which I have come across in my my OPD practice. Okay, this is a child, 2-year-old boy. You look at his weight, 13 kg, height 88 centimeters. He has basically thriving very well. He comes in with 3 episodes of ARTI and maybe a few episodes in between, and absolutely he has been well between these episodes. There's no family history of asthma, and but this time when I auscultated him, I found that he's got a wheeze. So what do you think this child has got? He's basically a normal child who has got a viral use. I mean, who has got a wheeze associated with a viral illness. All he needs is a bronchodilator. We don't need to worry too much about him. Tell the mother that yes, he has got a wheeze, but nothing to worry about. He will do very well. This is another child which I came across who is still under my follow. He's a 15-month-old boy. His current weight is 7.2 kg. His birth weight was about 3 kg. His height is about 75 centimeters. This child had a very severe episode of pneumonia at the age of 4 months, and he needed to be ventilated for about 4 days. He was an unimmunized child for pneumococcus. Okay, and about for 4 months after he was fine, and then he started developing repeated episodes of LRTI, for which he has been having repeated nebulizer, not with me but somebody else, and then he dropped it. This child, in between the episodes, have been reasonably well. Okay, and there's no family history of atopy. The clinching clue in this child is the looking at the height and the weight of the child. This child started with 3 kg and then he's only 7.2 at 15 months. So obviously we need to think about a systemic illness in this child. And I mean, the most common thing we probably think about is about a primary immunodeficiency, but for this child it was more a case of a subglottic stenosis, very severe subglottic stenosis, as a result of which he was having so much breathing difficulty, he was just not able to eat enough, and then he was just not thriving well. This child actually had to be sent for a surgery because his the third child, which is pretty much to akin to what my professors taught me. This was a 3-year-old child. She came to me with repeated episodes of wheezing. Her weight was 13 kg, height was 92 centimeters. So pretty much thriving well. I mean, not the most robust one, but still thriving well enough. Her first episode of breathing difficulty started at 18 months. Since then, she has had repeated episodes of breathing difficulty and treated with nebulizers and antibiotics. She has done well. Again, come back. In between, she has done reasonably well. Okay. And there is no family history of atopy. On examining the child, what caught my attention in this child was that she had symptoms mainly, I mean, her findings were mainly localized to the right inter and infrascapular area. So I asked her, in fact, to come back after a couple of weeks to again look at it. Again, the same findings. Got a X-ray. It did not show much. Okay, it showed some infiltrates, nothing much. And then went back onto the history. And then I was asking about how it started in the first episode. And then she said, see, child was playing very well. And then that evening she developed some breathing difficulty. So we took her to the doctor. He found some wheeze and then gave some medication. Became better. And then that was the story again and again. In fact, I sent this child for a strong suspicion. Maybe I thought maybe this child is a foreign body. Sent this child. In fact, got a repeat X-ray that showed there was some difference in the haziness between the right and left side. Again, teaching of my professor Dr. Srinivasan, and then the bronchoscopy was done, and then that child did have a foreign body. It was a groundnut, so as a we should have picked out quite early. And then the fourth case about a 2-year-old. She again very similar history with good weight child, thriving very well. First episode from 18 months. But this child started with the started with the viral illness, and then she has had repeated episodes where the wheezing responded very well to nebulizers, and the child was absolutely well in between these episodes. There was no family history. I think this is fairly obvious after all the talk which I have given. It's a episodic wheezer, isn't it? Episodic viral bronchodilators, and then depending upon the severity, consider using a dilated controller therapy. And then I have a 4-year-old child. His weight is 13 kg, pretty low for a 4-year-old, isn't it? Height is 94 centimeters, so he's more on a acute on chronic malnutrition kind of child. The first episode of breathing again at 18 months, recurrent episodes, but here the child is doing very well with nebulizers. The only problem is in between those episodes, he continues to have some symptoms. Child has had atopic eczema as an infant, and then also dad is asthmatic. So this child slot is more in terms of a multi-trigger wheeze. This child is somebody just with treatment with the acute episode, but also would need a inhaled corticosteroid. So just to conclude, what are things I think we need to remember when we come across a child with Wheeze? So any child who comes in with the what parental claim of a Wheeze, first confirm that it is indeed Wheeze. So it could be anything else. Just always try to either confirm it ourselves or get a video recording and then do it. So try to slot in the child into one of the possible clinical syndromes. Is it a normal child with a Wheeze? Is it a child with serious underlying illness along with the lung involvement? Is it a Wheeze with a respiratory mimic, or is it a true Wheezer? If it's a true Wheezer, again episodic Wheezer, in which case consider inhaled bronchodilator, and if it's a very severe or a frequent child, I mean frequent affect, then consider a daily control therapy with the montelukast or inhaled corticosteroids. If it's a multi-trigger wheeze, there is only one treatment, inhaled bronchodilator, and if it's really severe, consider inhaled corticosteroids. And that's it really. So thank you very much for this opportunity, and I hope I have hit at least a few boundaries